All right. Hi, Dr. Aurora. It's great to have you here with me today. And this has been I've been wanting to speak with you for quite some time now. We've had a couple opportunities where we have interacted on panels, and to me, it has been very interesting that we've sort of come to this point where we're very passionate about similar things, but we've taken a very different pathways, right, to get there. So we'll get into that a little bit. Um, and that topic is really women and sleep and women and sleep apnea is what I'm talking about. Um, but let me just start off by saying, it's wonderful to have you here, and congratulations on your promotion for being a full professor. So tell us just a little bit about your journey and why you chose to be chose sleep medicine as your career.
So, number one, thank you for having me on, Monica. This is just so exciting, and I love the fact that we're complementary almost in our passion, but our approach is complementary. Passion is similar. So I actually went back after training in pulmonary critical care, went back to train in sleep medicine because I was taking care of some veterans in East Orange, New Jersey at the VA there, and they had a lot of sleep issues, and I didn't feel equipped to take care of them. So I actually went back for more training and just fell in love with the specialty, and really was program building, clinical program building at Mount Sinai in Manhattan, and really wanted to also immerse in research. So ended up at Johns Hopkins, where I got a career development award and looking at sleep apnea and diabetes. And that was the first time that really started to see some differences between men and women and outcomes for sleep apnea and their responses to PAP therapy, positive airway pressure therapy. So that sort of fueled and excited me as to sex-based differences, and that's kind of how I've ended up here and got the wonderful opportunity to interact with you and just spend time with you. And it's been amazing the world that it's opened up for me and people like you that really advocate for women and health.
Thank you for that. No, I appreciate your kind words. And just an interesting nugget, while you were at Johns Hopkins, and I did not know you then, I was diagnosed with sleep apnea while launching, a program at the nonprofit that I worked on women and sleep. So it's just very interesting how it's all come together, right? So
Finally.
finally, so that is a little bit of that again, the parallel paths that we've taken. You're also the director of Women's Sleep Medicine Initiatives. Tell me a little bit about that. What does that entail, and what do you do, sort of, with that initiative?
Yeah, so this has been a very, very interesting opportunity and journey. So I am the director of Women's Sleep Medicine Initiatives for the Division of Pulmonary Critical Care and Sleep Medicine at NYU Grossman School of Medicine, NYU Langone Health. And they have a very active and large Center for Women's Health. And we started the sleep program there. I obviously am very immersed in that clinically seeing patients, but in that, I've also gotten the opportunity to really interact and develop collaborations and relationships with other women there that are involved in women's health, and especially the Midlife and Menopause Center. My sort of charge as director of Women's Sleep Medicine Initiatives is to really nurture and build those collaborations, have the opportunity to improve the sleep in women through research, through education, and through just clinical program building and growing. So that is the charge. And we seem to be making a lot of progress, a lot of exciting things on the horizon.
No, that sounds like a fantastic program. And absolutely, we need so much more attention. We need more women physicians coming in, and then we need to also take care of women with sleep disorders, right? So what does a typical day in a clinic look like that for you? And also, what type of patients do you see?
Yeah, so it's been really interesting because I see a range of patients from age 18 to age 90. I mean, I think my oldest patient is maybe even older than 90. And I see a whole range of sleep disorders, including sleep apnea, a lot of insomnia, especially in our peri and postmenopausal women. I see all sorts of other things, circadian rhythm disorders, central disorders of hypersomnia, and some of our younger people. And then I see a lot of people coming in saying, my sleep is unrefreshing. I'm not feeling like I'm getting good sleep, adequate sleep. And they have a lot of sleep tracking devices. So they want to talk about that. So that has also really engaged, especially our younger folks. I see about 70% women and 30% men. So we see men also at the Center for Women's Health, but it's basically all female faculty. So see a lot of things, a lot of referrals from cardiologists, the Midlife and Menopause Center, um, arrhythmias, people with diabetes, see all sorts of things, all sorts of sleep disorders, circadian rhythm disorders, really a very large variety of sleep disorders.
That's interesting. You see 70% women. How many do you think roughly you see or end up diagnosing women with sleep apnea,
Yeah.
especially since you're seeing menopausal to postmenopausal?
Yeah, so interestingly, we just did this analysis through our electronic medical records to look at um, how many new patients we saw at Center for Women's Health, new patients with sleep apnea. So these are not follow-up patients. These are not patients with other disorders, only with sleep apnea. And the number was about 800 in 1 year, just me alone, for new patients with only a diagnosis of sleep apnea. And interestingly, 50% of them were women. Just over a little over, like 51% were actually women. So the majority of those being in menopause.
Mhm.
So seeing a lot of sleep apnea that is finally coming to awareness both for providers and patients.
Well, that's good to hear because I know 10 years ago it was a totally different scene, right? I mean, so I agree, there's definitely a little more awareness. And I think we're still missing a lot, though, don't you think so?
Absolutely, absolutely, we are. Women present so differently, and they and even the providers, when they're complaining of insomnia or having to go to the restroom all the time, during the night, having to get up again and again to go to the restroom or waking up with headaches, um, people don't think of sleep apnea or a sleep breathing problem. And you're an example, Monica, of what women go through, and it's getting better, but we could still do even better, in my opinion.
No, and that is so true because I never even doubted I had sleep apnea. I had these random symptoms, and eventually I was able to sort of connect the dots. And when I actually heard sleep physicians talk about sleep apnea, that's when the light bulb moment went off, saying, well, maybe I should get tested, do a sleep study. I'd never even thought about that. And I typically tell people if you're going to annually to a dentist, if you're going to, get all these annual checkups done, you might as well just get a sleep study done just to at least see how your sleep is. Um, Tell us, you use two terms, perimenopausal. There's actually premenopausal, perimenopausal, and then we talked about postmenopausal. There's always a lot of confusion between these terms. So can you explain those terms, to the audience? Um, and then also tell me a little bit about the gender differences in how women present their symptoms differently than men, especially during this transition period that we see women going through this hormonal transition period.
Absolutely. These are fantastic questions. I'm going to just preface this by saying I'm not a gynecologist, but I've gotten very familiar with this terminology with my current role. So, perimenopause is when we start seeing some fluctuations in estrogen and progesterone. Women have a very complicated reproductive hormone balance across their lifetime, if you will. So, every month premenopausal, that's regular periods, regular menstrual cycles, we have fluctuations in estrogen and progesterone levels. And then during pregnancy, there's again variability and differences. And then in perimenopause, we start seeing fluctuations again. They are going up and down. So it's a bit hard to, some people ask me, well, should I get my hormone levels drawn as a lab work? And my answer is probably not, because they're so in flux that you really don't know what it means at that moment when you get the blood drawn. But what we know is that there's a lot of fluctuation. Women start having some symptoms, possibly. The symptoms can be things like night sweats or just thermoregulation, your thermostat, feeling, a lot of temperature sensitivities, and cognition, some brain fog, sleep starts getting more erratic, or you might experience some more insomnia, mood, depression, all sorts of things happen. Estrogen and progesterone are incredibly important at many, many levels. And that perimenopausal state lasts anywhere from 3 to 8 years. So it's a long period. And then when you don't have a menstrual cycle for 1 year, then you are considered to be in menopause. And all of that taken together, perimenopause plus that year, is called the menopause transition. And after that, you are post-menopause. So that's one way to think about it, and probably the way that most people sort of define and think of each stage.
Right. Now, that's so true. And then, how do the symptoms of sleep apnea, what do you see with regard to gender differences? Because often when we talk about symptoms, again, we talk in context of what men experience, right? The snorting, gasping, the pauses in breathing, but women can present symptoms very differently.
Very
And,
different.
and again, what can we tell women like to look out for that might even indicate or have them suspect that they might have sleep apnea? Because one of the things I hear often, women saying, I have insomnia. And it's become such a catch-all phrase now, saying I have insomnia. And they probably may not even realize that they might have sleep apnea, and they think that they have insomnia, or they could be a combination of both. So can you expand on that a bit?
Yeah. So men, like you have said, present in a very typical, conventional way. Loud snoring. Oh, it sounded like a truck. Um, they're sleepy, like really sleepy during the day. They stop breathing, they're gasping, choking, very, very sort of typical, obvious signs. Women, we use different words and we have different symptoms. So we may present with sleep maintenance insomnia, that is more typical. So having a lot of sleep fragmentation and awakenings, not sure what's causing them. We may have some nocturia, meaning we're getting up to to urinate during the night more than before. There's also an issue of headaches in the morning and depressive feelings as well. We may not describe ourselves as being sleepy, but we may feel this sort of profound fatigue more that is notable and different. So these are some of the things that we present with, very, very different than men. The problem is that some of the questionnaires and screening tools we use are based on symptoms or populations of men, and therefore they may even miss women because they're very, very much focused on symptoms that we have gathered from men in general.
So true. And I think that's something that needs to absolutely change in the sleep field. And I know people are working towards that. So hopefully we'll have more research and are able to capture some of that and be able to effectively screen and diagnose women, right? So what do you think women should do if they might think they have sleep apnea? So the first thing I think they might want to go, to their primary care physician, right? And any tips on how and when they should, first of all, seek a diagnosis and how that conversation should go? Because you're actually, by the time they come to you, they've actually gone through their primary care, and sometimes the diagnosis can take years, right? Or they've been,
Absolutely.
having these issues for years. So how does what do you suggest, to women who may think that they're experiencing some of the symptoms that you just mentioned?
Yeah, I think number one, their suspicion should be particularly heightened if they have issues with pre-diabetes, diabetes, blood pressure issues, heart issues, arrhythmias, if they're overweight, if they're obese, any of these things, these are things that should make them even more suspicious of sleep apnea. And, they sometimes need to bring it to the attention of their provider. I mean, we've done a good job of making our providers aware. But, not everybody is aware out there. So I think if you're having quote unquote insomnia and it's been going on for a while, especially, more than 3 months, let's say, it's time to talk to your doctor and say, do you think I need to see a sleep specialist? Maybe there's something else going on. If you've been told you're snoring, if you're getting up to use the restroom, anything that's kind of really disrupting your sleep, or if you're feeling sort of new fatigue or different level of fatigue, we're all busy, we all have limited bandwidth. I think it's really time to get your sleep looked at earlier rather than later. There was some evidence and some studies that showed that women ended up going to multiple physicians for symptoms that actually turned out to be sleep apnea. So they spent a longer time in that evaluation process trying to get diagnosed than men did. So I think raising that awareness, and especially if you have a comorbidity like, some kind of glucose or pre-diabetes, diabetes issue, metabolic issue, cardiac issue, you're the person that really needs to bring it up with your primary care provider.
No, that's so true. Something again, we've heard from couple, women who've had suspected they had sleep apnea when they were pregnant, and it typically tends to show up in the third trimester. And just like other conditions that come on during pregnancy, because it's such a short window, like gestational diabetes or let's say preeclampsia, which tend to go away once the pregnancy ends, right? But that puts women for high risk for high blood pressure or diabetes at later on in life. Is that something, do you think there's something to do with sleep apnea too, if they've already had it once during pregnancy? And is there research to sort of support that thought that this is something they're at risk for when they're older?
Absolutely. In fact, there's a guideline that just came out for the American College of Lifestyle Medicine, and women that had gestational diabetes or preeclampsia definitely need to get checked for sleep apnea. Um, you know, that's a population where we can really catch them early, and make a difference. And there are, there's evidence that sleep apnea can lead to adverse outcomes in the baby. So this is something that we really want to focus in on and, really take care of the baby and the mom, and diagnosing and treating the sleep apnea during pregnancy or, even postpartum. I mean, it's never too late. Uh,
Mhm.
to make the person aware and get them diagnosed.
And let's just be clear, women don't have to wait until they get to a sleep clinic. They can ask their primary care physician to order a sleep test, right? And they
Absolutely.
can even get a home sleep test. And if there is a concern with the home sleep test, which tends to be, we've found that in women, and please correct me if I'm wrong, that women can then go still ask for a in-lab study so that they can be accurately, screened.
Yes. So the home sleep testing it has been a very powerful tool in the sense of really changing the burden of doing an in-laboratory test for patients and the wait time. The downside is that many of them are more focused on oxygen levels and really looking only at those breathing problems that are associated with oxygen drops. Um, but you can have breathing problems where you don't drop your oxygen a lot, but you end up waking up. And interestingly, women tend to do that more than men. They tend to have more of those awakenings with the obstructive breathing events. They tend to not completely collapse their upper airway, but partially collapse it. And those events that are associated with the awakenings, may be missed
Mhm.
on the home sleep test because even though they claim that they're capturing arousals, they're not really seeing them in association with or linked to the breathing events. So there is some school of thought that doing the in-laboratory study on women will yield better results. It may be more sensitive in women. So while the home sleep testing has really increased our ability and provided convenience to the patient and increased our ability to diagnose and provided convenience for patients, we have to be really careful because, if a woman that has a lot of insomnia as her presentation of sleep apnea has a negative study, but is continuing to have symptoms, then we don't want to miss it in them. So we want to really proceed with the in-laboratory sleep study.
So you're saying even if a sleep study, home sleep study is coming out positive, still a good idea to go follow up with a sleep specialist, go have an in-lab sleep study too.
Yeah,
Or
if it's
if
negative,
if
meaning
it's negative, then just go. Okay.
I think then if you're still having symptoms and your provider has a high clinical suspicion, well, that's an indication to go ahead and have an in-laboratory sleep study. Absolutely.
And just for others, just to let them know, and I don't know if you've seen this, but we do have a resource on our website for women that tells them the symptoms that they should look out for and use that as a conversation starter with their physician. So on the back end is information for the physician. So, always encourage everyone to take a look at that resource. And it's been pretty good. I've had people tell me that they have used it and actually realized that they have had symptoms and encouraged to go. So that's sort of, I love to hear that because that's like the self advocacy aspect, right? We're actually
Absolutely.
to take charge of their health and sort of follow up.
That
So
that is wonderful and so important. So important.
right. No, no, so true. Um, we've talked about tell me a little bit about the insomnia and the sleep apnea connection. Let's talk about it because the symptoms tend to overlap, but the treatment is also very different, right? The approach to it is going to be very different. And more often, you women are given medications to treat the insomnia, but that can be not beneficial when you have sleep apnea. So let's discuss a bit about that.
Yeah, I think this is a really important topic. So what you're referring to is comorbid insomnia and sleep apnea, something that is the acronym is COMISA. It is an area of active investigation. There's a lot of interest in this, part of the reason is because there has been shown that there are worse outcomes in terms of quality of life and cardiometabolic outcomes, even if you have COMISA versus if you have either of those disorders alone. And the issue is, there we don't know for sure, but it seems like probably both need to be treated. And you have to be careful because when you give somebody a medication for insomnia, some of the medications, not all of them, but some of them can actually affect the patency of the upper airway. So, if they make the upper airway muscles more relaxed, then they're more likely to collapse and cause more sleep apnea. And the fact of the matter is that the best therapy, hands down, evidence-based for chronic insomnia is cognitive behavior therapy focused for insomnia. So you want to be really careful about giving medications to people that have insomnia symptoms. And in your, especially sort of midlife to older women, you want to make sure that they don't actually have sleep apnea. So when somebody comes into me and complains of insomnia, and they're in that right age range or they have some risk factors, I always test for sleep apnea first, to make sure that that's not an issue because I don't want to miss that. It has a lot of adverse health effects. So I don't want to miss that. And then once we treat their sleep apnea, then, I think we're in a better position and in a safer position to treat their insomnia. But there is active research about which one should be taken care of first, and, or should it be in parallel? So this is an area of active interest and research that is ongoing in the sleep field.
So again, this brings in the, sort of the awareness aspect for women too, that always ask about sleep apnea, even if you think you might have insomnia, but at least make sure that, you're at least having the conversation about both, with your physicians.
Absolutely.
Let's talk a bit about treatments. And, you did mention, a couple already, for one for insomnia and then sleep apnea. But um, let's talk about the different treatments out there. And then also, what about the HRT, hormone replacement therapy? And a lot of women, when they're approaching menopause, that's the conversation they start having with their doctor, especially if they're having vasomotor symptoms, right? Like the night sweats or,
Absolutely.
all the other symptoms that are associated with the menopausal transition. Um,
So I'm going to start by saying estrogen and progesterone and the loss of those two very important reproductive hormones in menopause can really wreak havoc. They do a lot of things in the sleep-wake centers of the brain. They're very important in the regulation of temperature, in mood, all sorts of things. They're also incredibly important, especially estrogen, in the upper airway muscle, both development and the function of the upper airway muscle. So when menopause hits and those hormones go away, we actually see there's evidence that the upper airway doesn't function as well and may lengthen more than it does in men of that same age, which makes that upper airway more unstable. So it would naturally seem that if you give what's called menopausal hormonal replacement therapy, because the dosage is a bit different than hormone replacement therapy, that maybe it would make sense in terms of sleep apnea. But the evidence is a bit thin as of yet, but hopefully mounting. There are some epidemiological studies, so large population-based studies. And they did show, in fact, that estrogen replacement therapy, those on it versus those not, had less sleep apnea. That's from something called the Sleep Heart Health Study. There are some other smaller studies. So, it's mounting, it's there, but I think there definitely needs to be more research in terms of the menopausal hormonal replacement therapy and sleep apnea. It also, there's a certain time where the benefits really outweigh the risks in very specific patient populations. So earlier on in menopause, within the first decade, you obviously want to be very careful about things like family history or personal history of any kind of reproductive related cancers or malignancies, cardiovascular risk, all of those things. But I think in the right patient population and in the right person, it can be extremely life-changing in a very positive way. So it can really help. So progesterone, it turns out, actually binds to some of the sleep-inducing receptors called GABA receptors. So it can really help with sleep, kind of quality and onset and maintenance. And estrogen can really help, especially with those vasomotor symptoms, those hot flashes, and both can help with sort of mood and just cognition. But where we're going to land in terms of sleep apnea, that a bit of that remains to be seen. But I think there's a lot of mounting interest in this area.
No, definitely. And I think with regard to treatments too, there's so many that are coming now to market. There'll be options for patients, and again, we'll need to know more about what women prefer, right? And we're starting to
Absolutely.
bit of that data come in now. But again, depending on where they are with the severity of sleep apnea. Do you want to say something about the treatments landscape?
Wow, there's so much coming out for sleep apnea. We're in such an exciting time. Of course, I think most people know about and are a little apprehensive or fearful of positive airway pressure therapy, the dreaded machine. But I have to say, even those have really improved over time. They're quiet, they're more comfortable, there's humidification that is heated, they self-adjust. They're quite they've become quite advanced and smart. And there are literally hundreds of types of masks out there. So even that has, that's improved a lot. I'm always pleasantly surprised when patients are pleasantly surprised with how well they're tolerating PAP therapy. There is oral appliance therapy, OAT, which basically at this point is more for mild or mild to moderate sleep apnea that can be given as first line therapy. Most of those devices, what they do is they move the lower jaw slightly forward during the night and open up that air space right behind. Um, for some people, they are absolutely amazing. They work great. Um, and some people prefer them over PAP therapy. And typically what happens, they come with a realigner that you use for a few minutes in the morning. The nice thing about PAP therapy, I will tell you that it's sort of multi-level. So it treats the entire upper airway. It makes sure that entire upper airway is patent. The oral appliance therapy really kind of hones in or focuses on specific area. There's also neuromuscular electrical stimulation devices now. There's one that is called, it's a hypoglossal nerve stimulator called Inspire. That is an implantable device. There are two of those nerves, and it acts on one of them. It's almost like a, a pacemaker, it looks like under the skin in some ways. And it's essentially stimulating the nerve when you sleep, pulling the tongue forward and opening up the air space. You have to qualify for it in the sense you need to try PAP therapy first. And if you're intolerant, your upper airway has to collapse in a certain way for you to qualify. Otherwise, it may not be effective. It's called anterior posterior collapse.
Mhm.
There's another device that has been FDA cleared. It's called Genio, and that one actually works on both sides. So it works on both sides, bilateral hypoglossal nerve stimulation. There's a device that's just a tongue stimulator or tongue trainer called Excite OSA. You use that during the day only. There's one pretty good randomized controlled trial for that, but that's primarily in mild sleep apnea. And of course, one of the big things that has come out that is changing the landscape is tirzepatide, which is a GLP-1 GIP. It's got two medications in it, incretin molecule that basically really focuses on weight loss. And that is the mechanism by which it causes improvement in sleep apnea. As far as we know so far, there may be other data. It typically reduces the severity or the number of events by 50, 60%. That study, which came out in June 2024, and the FDA actually approved Zepbound specifically for sleep apnea December 2024, but it showed a decrease of about 50 to 60%, and 30% of people actually got cured. You have to be the right severity of sleep apnea. You have to be, um, more in the obese,
Mhm.
sort of technically obese weight range to qualify. There are other pharmacological agents within that category coming out. There are a lot of them on the horizon. And then there is a medication called 8109, which is also just finished some phase 3 studies, so that'll be exciting to see. That is not weight-based, that's actually a different mechanism, very sleep apnea specific. And then there are, of course, other surgeries, multi-level surgeries that are more involved, that, otolaryngologists do or sleep apnea surgeons. So there are a lot of options now that are starting to emerge. It's pretty
No,
exciting.
it is pretty exciting time, and I think patients need to understand it's just not always the CPAP. There are so many other things that they can try, and again, depends on the severity of the OSA or what they can try first, and then or in combination,
Yeah,
something
I mean,
better. Yeah.
I didn't even mention positional devices
Yeah.
sometimes, like you said, in combination, or, this one didn't work so well, now you move on to another therapy. So it's pretty exciting times.
No, absolutely. Let's spend just quick couple minutes on implications of not treating sleep apnea in women. I mean, again, given your background and your work, even on the cardiometabolic side, let's just kind of think about some of those scenarios or the patients that you're seeing. You did mention, before that you do see women coming with, perhaps from different clinics, right, with other conditions or health issues. Yeah, can you expand a bit more on
Yeah.
that? If
So I think the last, I would say, maybe 15 years, um, we're starting to see that there may be different implications of untreated sleep apnea, or, just sleep apnea at baseline, um, before the treatment starts in men and women, all the way from physiological stress like biomarkers to different kinds of intermediate outcomes, to epidemiological Medicare databases that have shown that sleep apnea might have different outcomes in men versus women. And interestingly, a lot of that data is starting to point to, well, it may actually be worse in women.
Mm.
Some of these biomarkers seem to, be worse in women. Some of the diabetes, the hypertension, those things possibly are different or worse, or, in women. So there's a lot of emerging data. And what we have focused on in our sort of investigation so far is looking at markers of that we would see overnight that indicate that the body is under stress. So inflammation or oxidative stress, we did find, interestingly, that in women with diabetes and sleep apnea, they seem to have more of that oxidative stress when you looked at certain molecules overnight than the men did. We also saw some differences in terms of how they respond to therapy. And, we're continuing our research now in women and men with sleep apnea, but without the diabetes, and we're still seeing some differences. So, I think we have to start being aware that, especially with the menopause, because estrogen is extremely protective physiologically, it is an antioxidant, so it helps reduce oxidative stress, which is involved in heart disease and diabetes and just the aging process. And estrogen seems to help in that. And that when you add another physiological stressor like obstructive sleep apnea on top of the menopause, and now there's more of that oxidative stress, that the women may actually really accelerate in terms of getting adverse health outcomes even more than the men suddenly, um, with menopause. And now you have more sleep apnea and menopause. You have women now that used to have this big antioxidant, and now all of that is gone. And now you put that sleep apnea on top of that, and the women tend to really be at a disadvantage health-wise.
So interesting. And actually, thank you for that explanation because I've always wondered, like a lot of the chronic health conditions, we know more women are affected by them, right? Whether it's heart disease, diabetes. It's always wondered, how is that connection with sleep apnea? Why aren't we seeing more women with sleep apnea? Because it's almost like it sort of sets them on that path to these other chronic
Right.
conditions. Plus, women, there's sex differences in how, women respond, their immune system responds, right? So again, it's nice to see sort of all of these dots now being connected. So thank you for that. So I just have this final question for you as we wrap up this conversation. What message do you have for women? And what do you want to say to them? And also the physicians, who are maybe perhaps not as aware that women can have sleep apnea too. I'm talking about primary care and sometimes even sleep physicians, because for a long time in this field, and that myth continues to perpetuate even to this day, that it's mostly men who have sleep apnea. So, what's your takeaway message here?
So and Monica, I think your voice in this is even more important and has been more of an advocate for women than anybody else I know in the field. So kudos to you on that, because you've really set the stage and set us up. So I think, you know, both need to be done in parallel. Physicians and patients need to be made aware in parallel. Um, I think we need to get the message out that sleep apnea presents differently in women. That's number one, because that is one of the first reasons it's getting missed, is because we present differently. So I think that's something that the physicians need to be educated on and understand. That's the first thing. Number two, I think there is, you know, the fact that sleep apnea was a man's disease, or is considered a man's disease, is very much like cardiovascular disease, right? Like we thought, oh, that's men. But now we know that it's the leading cause of death in women as well. And the fact of the matter is, I think we have to look at sleep apnea differently and in that same way. And the data is there. We used to think that it was 3 to 5 men per one woman in in the general community. In the sleep clinics, 8 or 9 men to each woman, but that ratio in has been shown to not actually be so true anymore. So I think we're starting to see that, especially post-menopausal women, it's really approaching men, and it's the ratio is more like 1.5 to 1. So, I think that data came out in 2019. So we really need to get the message out in parallel. I think we went a long way with, the essential eight that the American Heart Association identified sleep as an important factor and a pillar of good health. And I think we have to keep messaging that and look at different screening mechanisms,
Mhm.
different screening tools. I think at least where I am, we've raised a lot of awareness about sleep apnea in women. And I think we have to really message that across the country. And we're starting to, but we have a ways to go yet. And, patient awareness ads, more focused conferences on women's health, all of these things go a long way.
No, that's great. And just I'll end this on an anecdote because since you brought up like where we are right now, how it used to be in in cardiology or cardiovascular diseases, right? Or heart disease. And a long time ago, I had a conversation with one of the pioneers in that field, who was a woman cardiologist, and she said back in the 50s when they used to go to the conference, there were used to be discussions about how women can take care of their husbands who had heart disease. We've come a long way, right? Now recognizing heart disease is number one killer in women. And I think there's hope for sleep apnea that we're starting to recognize these differences now and that we can start to identify women who have sleep apnea and actually treat them appropriately. So some of the things, the challenges and the struggles that we've had in the cardiovascular space, I think we can learn something from that and see where we are with the sleep apnea and hopefully get that treatment to the women who need.
Absolutely.
Yeah. Well, it was wonderful to have this conversation with you today, Nisha, and thank you again for being here
And thank you for inviting me on this incredibly important topic.
and again all the best with your work and once more congratulations on your promotion.
Thank you so much.